Hi, everybody, and welcome to our module on eating disorders. Eating disorders are psychiatric conditions in which patients develop abnormal eating patterns, and these eating patterns either disrupt their physical health or their psychosocial functioning or both. In general, they are more common in women, and they usually present in adolescence or young adulthood. And there are a number of DSM-5 eating disorders, but the three that you should know for step one and that we'll talk about in this video are anorexia, bulimia, and binge eating disorder. We'll start with anorexia nervosa, which most people simply call anorexia. In this condition, patients diet and exercise to the point that they develop a dangerously low body weight. The WHO definition of the body weight for anorexia nervosa is less than 18.5, and you may know that a normal BMI is about 20 to 25. In addition to the low body weight, patients with anorexia have an intense fear of gaining weight. They have a distorted perception of their body weight, so even though they are underweight, they may feel like they are fat or obese. And there's an increased mortality among patients with anorexia from malnutrition. This is a very dangerous and potentially life-threatening condition. And this is a picture of a woman with anorexia here. You can see she's so skinny that you can see her bones. But if you had a patient like this with anorexia, she might think she's overweight and might be restricting her calories despite having this physical appearance. Anorexia often coexists with other psychiatric conditions, especially depression, but also anxiety and OCD and PTSD and substance abuse. And often one of these other conditions is secondary to the eating disorder. And if the patient is able to restore a normal weight, the psychiatric condition will get better. This is especially true for women who have anorexia and are depressed. When they get treatment for their anorexia and they gain weight, their depression also improves. For step one of your boards, they're going to expect you to know all the physiologic effects of anorexia, which are basically the physiologic effects of malnutrition and low calorie intake. So let's go through those now. First of all, remember this condition is much more common in women. So women who have anorexia will have decreased GnRH release from the hypothalamus. This will lead to less release of LH and FSH from the pituitary, and that will lead to amenorrhea. This is a classic finding in women who have anorexia nervosa. This is called functional hypothalamic amenorrhea, and it happens when there is poor calorie intake and generalized stress. Basically, the hypothalamus releases less GnRH. Patients with anorexia can also develop electrolyte abnormalities. Basically, what happens is they do not take in enough calories to fuel the cells of the nephron, and therefore the kidneys cannot concentrate the urine. This leads to free water loss, and then these patients drink lots of water because they're thirsty. They don't want to drink anything like juice that has calories in it, so they take in just water, and this can potentially lead to hyponatremia. It's rare, but it can occur in patients with anorexia. In addition, they can become volume depleted from the free water loss, and this can reduce their GFR. Now, normally when the glomerular filtration rate falls, the creatinine level goes up. However, it can be low or normal in people with anorexia, and that's because creatinine is derived from your muscle mass, and these patients have very low muscle mass. In addition, some patients with anorexia purge, meaning they cause themselves to vomit to get calories out of their stomach, and when people do this, that can also cause them to lose potassium, and they can develop hypokalemia. Bone density falls among women who have anorexia nervosa. First of all, as I told you before, there's less estrogen because of suppression of the hypothalamic pituitary axis. In addition, these women are under stress, so they have high cortisol levels. So this combination decreases bone density. These women lose cortical and trabecular bone, and they can develop osteopenia, osteoporosis, and even fractures like shown on this picture here. Your bone marrow will become suppressed if you don't take in enough calories. So people with anorexia can have anemia, leukopenia, thrombocytopenia. They can essentially have pancytopenia because they aren't taking in enough calories and energy so that their bone marrow can work. Now, not all patients with anorexia nervosa will come to the doctor and admit that they have an eating disorder, so you need to be able to recognize the physical exam findings of anorexia. First of all, by definition, people with anorexia will have a low body mass index. As I told you before, the definition of anorexia is less than 18.5. Mild anorexia is a body mass index from 17 to 18.5. Moderate is in the 16s, and severe is in the 15s, and extreme is less than 15. On exam, you can see bradycardia and hypotension. These are all just due to the fact there's not enough calories for the body to work normally. Bowel sounds may be decreased because the person isn't taking in much food. The skin will develop what's known as xerosis. This is dry, scaly skin. There can be hair loss because there aren't enough calories to grow normal hair. And where hair is growing, the classic finding is to see what's known as lanugo hair growth. This is a picture of lanugo hair here. This hair is soft and very fine. If you ever meet a patient with anorexia, you'll feel their hair and you'll immediately know what lanugo hair growth is. It has a very unusual texture compared to normal hair. The treatment of anorexia nervosa includes something known as nutritional rehabilitation and psychotherapy. One thing you always want to remember about anorexia in terms of board questions is that it is generally not treated with medications. Medications aren't very effective. It's usually treated with therapy. Nutritional rehabilitation involves structured meals with observation and daily calorie goals, and the idea here is to try and get the patient to eat a healthy diet and start to gain weight. And then many forms of psychotherapy are used to try and address the underlying issues in patients with anorexia nervosa. When drugs are used, they're not used as first-line therapy, and the drug that has the most evidence of benefit is olanzapine, which is an antipsychotic. The reason this drug is somewhat popular for treatment of anorexia nervosa when drugs are necessary is that it causes weight gain, and this can be beneficial for patients who have anorexia nervosa who are dangerously underweight. When you begin to feed patients with anorexia to get them to gain weight, you have to do this very carefully, or they can potentially develop a life-threatening condition called the refeeding syndrome. The hallmark of the refeeding syndrome is a low level of serum phosphate, or hypophosphatemia. The reason this occurs is because patients with anorexia have a low phosphate level at baseline from poor nutrition. They're just not eating enough phosphate. When you begin to feed them, you give them glucose, and this stimulates insulin release, and insulin activates metabolism. When this happens, there'll be a further decline in the serum phosphate level as cells begin to take up phosphate. And what can happen is there's just not enough phosphate around to make ATP. Remember, ATP is adenosine triphosphate, and you need phosphate to make ATP. And if there's a loss of ATP, what will happen is that the heart and the lungs will stop working. Basically, patients won't have enough ATP for their heart to work, and they won't have enough ATP for their muscles of respiration. Most of the fatalities in the refeeding syndrome are cardiac. This is because the heart just doesn't have enough energy, so there's poor contractility and a low stroke volume. This can lead to heart failure and arrhythmias. The way this is avoided is by slow refeeding. You gently increase the calorie intake among patients who have anorexia with just a little more calories each day beyond what they were taking in when they were anorexic. Basically, you slowly increase the calories, and this allows the body to adjust and avoid the refeeding syndrome. Moving on, let's talk about bulimia nervosa, which most people just call bulimia. Patients with bulimia do two things. First of all, they binge eat, which means they consume massive amounts of calories in a short period of time. Potentially over just a few hours, they may consume thousands of calories. Following that, they feel horrible and they engage in inappropriate compensation for the binge eating to avoid weight gain. Some of the things people with bulimia may do include vomiting, which is called purging. Some people take laxatives, diuretics, or enemas. The idea here is to increase their urine output or their number of bowel movements to try to lose weight. Some people will excessively exercise, potentially going to the gym and working out for several hours at a time. And other people will fast or severely restrict their diets. And all of these are a compensation for the binge eating. To meet the criteria for bulimia nervosa, a person has to engage in binging or inappropriate compensation for binging at least once a week for 3 months. People with this condition, in contrast to anorexia, usually have a normal weight because they are overeating and then restricting, but on balance, they end up not gaining much weight or not losing much weight. So this distinguishes bulimia from anorexia. And just like anorexia, bulimia commonly coexists with other psychiatric disorders. Many patients with bulimia suffer from anxiety, depression, PTSD, or substance abuse. There are many ways that patients with bulimia compensate for their binge eating. As I told you before, some patients exercise excessively, some patients starve themselves, but the classic form of compensation in bulimia is vomiting or purging, and purging has some special medical complications you should know about. First of all, purging, just like any cause of vomiting, can lead to a contraction alkalosis and hypokalemia from loss of potassium in gastric contents. In addition, if a person presents with an unexplained contraction alkalosis, that person may be hiding the fact that he or she is bulimic and is purging. And one way you can sort this out is by testing the urinary chloride. The urinary chloride is low in patients who are surreptitiously vomiting, and I talk about this in more detail in the renal video on metabolic alkalosis, but you should be aware that one of the classic presentations of a person who is bulimic is to have an unexplained contraction alkalosis with hypokalemia, and that's from vomiting. Patients who are vomiting classically develop swelling of their parotid glands from the exposure of gastric acid in the mouth. This is called parotid gland hypertrophy or sialidinosis. In addition, they can develop erosion of their dental enamel, and once again, this is from gastric acid being in the mouth over and over again. Russell's sign is the classic sign of bulimia. In patients who are purging, they will stick their hand into their mouth and their knuckles will get scratched by their teeth. So they will have scars on their knuckles from induced vomiting. And this is a picture of Russell's sign here. Basically, it just means irritation and scarring on the knuckles. The treatment of bulimia is with nutritional rehabilitation, teaching patients healthy eating habits, also psychotherapy, and also SSRIs. The last eating disorder we'll talk about is binge eating disorder. As the name implies, patients with this condition binge eat, so they compulsively overeat excessively large amounts of food, often eaten quickly. The patients feel that they lack control, and they feel shame and embarrassment. And many of these features are similar to what happens to patients with bulimia. But in contrast, patients with binge eating disorder do not engage in inappropriate compensation. Therefore, they gain lots of weight. And also, like the diagnosis of bulimia, to meet the criteria for binge eating disorder, patients have to engage in binge eating at least once a week for 3 months. Binge eating disorder often occurs with other disorders like anxiety and depression. And as you can imagine, studies show a high risk of type 2 diabetes. Diabetes is associated with obesity, so patients that binge eat obviously can develop that condition. One thing that's very high yield to know about binge eating disorder is that the first line treatment is psychotherapy or cognitive behavioral therapy. This has been looked at in large clinical trials, and they've shown a large effect of therapy greater than the effect of medications. So if they ask you for the next best step in a person with binge eating disorder, the answer is usually psychotherapy, not drugs. SSRIs can be used, but they are less effective. And then finally, beyond SSRIs, there are two special medical treatments that are sometimes used in binge eating disorder. The first one is lisdexamfetamine. This is an ADHD stimulant, and the second one is topiramate, which is a seizure drug. There have been clinical trials conducted with both of these medications, and they have shown an increased abstinence from binge episodes among patients with binge eating disorder. And in addition, both of these drugs lead to reduced weight. So once again, always remember that therapy is the first line treatment for binge eating disorder, but beyond that, SSRIs and these drugs are sometimes used. And that concludes our video on eating disorders.